Shubham? That's right. You'll be speaking on Seeing Through the Bleed, role of FAF imaging in the management of traumatic submacular hemorrhage.
Right. So, good morning, everyone. I'm talking about role of fundus autofluorescence imaging in the management of SMH. So, these are the contents that I'll be covering. So, just to give a brief introduction, to define submacular hemorrhage is a collection of blood due to any etiology below the neurosensory retina. And as of now, there's no gold standard treatment for each cause or each presentation of a submacular hemorrhage. To talk about goals of treating a submacular hemorrhage, we aim to evacuate the blood from beneath the fovea, and we try to prevent as much damage to prevent damage to the photoreceptors as much as possible. So the current management options that we have include intraocular gas tamponade, a tissue plasminogen activator, anti-VEGF injection, or a pars plana vitrectomy. So coming to my study, the aim of the study was to evaluate baseline characteristics of fundus autofluorescence in patients with submacular hemorrhage. It was a retrospective study where we recruited all treatment-naive fovea involving submacular hemorrhage patients in which the hemorrhage was more than 2 disc diameters. It involved all etiologies. And the only thing we excluded were pre-existing retinal lesions that were not contributing to the submacular hemorrhage, such as diabetic retinopathy, any retinal breaks, etc. So we recorded the patient demographics. We took a detailed history. We recorded the best corrected visual acuity at presentation and at follow-ups. And we acquired good quality color fundus photograph with an Optos, an SD OCT with Heidelberg, and blue wavelength fundus autofluorescence images with Heidelberg as well. And then we recorded the treatment received by each of the patients, and we recorded the follow-up details. So coming to imaging, on a color fundus photograph, we recorded the finding as the color of SMH, whether it was red or yellow, and any other relevant clinical findings. On OCT, we recorded the reflectivity of the submacular hemorrhage and the presence of backshadowing and the presence of any choroidal neovascular membranes or any rupture at fovea. On the fundus autofluorescence, we recorded whether there was a hypo or hyper autofluorescence. Then we recorded the treatment received by each of the patients, where it involved either observation, intravitreal gas tamponade, intravitreal tissue plasminogen activator, anti-VEGF injection, or pars plana vitrectomy. So treatment success was defined as reduction, displacement, or elimination of hemorrhage from beneath the fovea, evaluated during the follow-up visits within 3 months after presentation, as observed on a color fundus photograph and confirmed by OCT and FAF. So to look at the results, out of a total of 80 patients that presented to us, 47% of them had a subretinal hemorrhage that did not involve the fovea. For 29% did not have good quality images. So out of the 24%, it involved a sample size of 19 patients. Out of those 19, 13 were male, 6 were female. And 11 of those submacular hemorrhages was caused by neovascular AMD, 7 by trauma, and 1 by myopic CNVM. Now, when we looked at the characteristics of SMH and compared them to the outcome of SMH as defined by our treatment outcome, the color of heme, where it was red or yellow, did not really affect the outcome of SMH. Reflectivity as well did not affect. Only the autofluorescence of heme showed a positive correlation with the outcome. None of the treatment outcomes also showed any positive correlation with the outcome of submacular hemorrhage. So to look briefly at the composition of submacular hemorrhage, a fresh submacular hemorrhage would look red on color fundus photo, would have a heterogeneous hyper and hypoautoreflectivity on OCT, and would have hypoautofluorescence. Whereas an older blood would be yellow, would be homogeneously hyperreflective, and would have hyperautofluorescence. So pneumatic displacement is usually used to make the SMH fresh, make the SMH mobile, and is used when the SMH is mobile. TPA is used to keep the blood mobile, and a pars plana vitrectomy can be used in large SMHs. The limitation of my study was a small sample size, and the data was insufficient to compare the treatment outcomes of the different treatment modalities. Also, we use blue light autofluorescence, which can interact with macular pigments, where a green light fundus autofluorescence would have been better. So to conclude, fundus autofluorescence can potentially detect changes in the composition of extravasated blood in a submacular hemorrhage, wherein adjunct with OCT and clinical color fundus photo, it can be employed as a tool in guiding the choice of treatment modality. It can also help in prognosticating the submacular hemorrhage patients. These are my references. Thank you.
Thank you very much. I think it was well presented. All of you have well presented, and your topic was something unique. And so, well, of course, I myself was seeing quite a good pictures I was seeing, and which I've not seen it before. So that's it.
I mean, So you mentioned the only thing that correlated was the color.
Color.
Correlated with treatment success?
Yes, sir. So that was a Spearman's correlation test where the p-value that was given was it was a moderately positive correlation. The coefficient was 0.6.
Okay. But in those with yellow color, is it?
No, no. So those which had a hypo autofluorescence on fundus autofluorescence
And
had
majority of the patients in that group were treated with which modality?
so that's what the treatment modality did not really affect the treatment outcome. So that did not really correlate with the because I mean such data can be skewed because it's a small sample size. So that's why to correlate better with the treatment modality, we need to have more samples in each group of the
Treatment
color as well.
modality. Okay.
Yes,
But do you think that your treatment modality can change?
100%. Yes, sir.
In what way?
So the presentation, whether there's a fresh blood or an old blood, that would, I mean, clinically it feels like that should be the most important.
No, I'm talking in terms of your
and
presentation regarding the color coding.
Right, sir.
So,
So,
if you can always make out the other way around also.
Yes, sir. Yes, sir. So
whether it's a fresh bleed or a
Right.
old bleed.
Right. So in case of a fresh bleed where we would do a intraocular gas tamponade primarily, it would yield better results in a fresh blood. So the color then would correlate with the treatment outcome, with the success of SMH management, only if the correct management has been employed.
Okay, thank you.
Thank you, sir.